Good evening, everyone. Welcome to this first test and discussion on the Mortimer Green app. And at the outset, both me and Dr. Vinayak would like to welcome all of you. So the purpose of having these tests and discussions before the September exam is that we are aware that a lot of you would be, in the final stages of your preparation, and we would continue these tests and discussions till September, so that you can just revise the topics that you've already read, and you can attend these questions, and then during the discussion we'll highlight the important points which are usually asked in the exam. And also one more thing, that is the difference in management, say in India or in Pakistan versus UK, right? So in our countries versus UK, and those are the differences which are commonly asked in the exam, and students often make a mistake there. So with that said, let's start with the discussion. Please feel free to ask your questions in the chat box. We'll be happy to address them. And I will be covering up some additional questions as well, which were not there in the test paper, so that you're fully prepared with this topic. Now, usually from breast, you will get at least 2 to 3 questions which are asked in the exam, right? So minimum 3 questions you will get in the exam. Sometimes you can have up to 4 questions as well. And they are usually a mixture of 2 questions will be from benign disorders, one from malignant disorders, and one would be based on the investigations or pathology. So that is the usual distribution which is asked in the exam. So the first question, I think so, this was a very straightforward question. And as surgeons, I'm sure all of you are aware of it. But we'll also have a few orthopedicians in the group. So, I mean, for your benefit, this lady, Mrs. Khanna's sister, has recently been diagnosed with fibrocystic disease of the breast. She now has some concerns about her condition. Identify the incorrect statement. And there's one change which I wanted you to make here. The point number E, instead of premenopausal, it should be premenstrual, right? It should be premenstrual. So you can just make that change. And right, so what do you think would be the answer for this question? Everyone, I'm sure you would have attempted this. What is the answer to this question? Let's look at the answers. Right, so let's look at one statement at a time. Fibrocystic disease, fibrocystic, correct. D is the correct answer. That is absolutely correct. So it is a benign condition and can be pre-malignant if it is associated with atypia. So that is correct. If it is associated with atypia, then you can have a risk of malignancy. But standalone fibrocystic disease will not carry a risk of cancer. The type and frequency of symptoms can vary, but it most commonly affects the upper outer quadrant. This is also true. This you should know. Mostly patients will come with problem in the upper outer quadrant. It is not considered as a disease, but an aberration of normal development and involution. So this term ANDI, aberration of normal development and involution, this basically encompasses all the benign breast conditions. Right from puberty till the time of menopause, most of the benign breast conditions fall under the gamut of aberrations of normal development and involution. Okay. Right. Now, symptoms vary cyclically, typically peaking in mid-cycle. So they don't peak mid-cycle. There's a premenstrual peak which is seen. Okay, so patient will typically complain that just before the periods, the breasts are very tender and there is lumpiness. But as the periods start, the breast becomes softer and the pain also reduces. And this is thought to be due to cumulative hormonal exposure because of its onset in the premenstrual phase and improvement after menopause. So regarding the treatment of fibrocystic disease, what is written in Bailey is that adequate breast support should be given, and primrose oil. So primrose oil, there are various studies on this. Some say it's just a placebo, whereas some studies actually claim that it is beneficial. But in Bailey, this is written as one of the management options for fibrocystic disease. So we will have to remember that for the exam as well. Right, so I've already covered these points. Any question any points which you want to raise regarding this question, or we move on to the next question? Okay. So Miss Williams, while undergoing her annual medical checkup at her general practitioner, was discovered to have a lump that is clinically suspected to be a breast mouse. So usually, like I said, the questions which come from breast disorders are very simple questions, right? They don't ask very tricky questions until unless it's a correlation with radiology and pathology. That is where students usually make a mistake. Otherwise, primarily from breast, there are very straightforward questions which are asked. There are certain exceptions which I'll tell you as we keep on discussing. So this was thought to be a breast mouse. Now, breast mouse, we know that this is a fibroadenoma. This is the typical definition or a description of a fibroadenoma. And typically, you'll have a young girl with a mobile breast lump. Which of the following pathological features will be against the diagnosis? So if you look at this, grossly, it appears to be well circumscribed with a firm consistency. It ranges from less than 1 to 5 centimeters. And any fibroadenoma which is more than 5 centimeters is labeled as a giant fibroadenoma. This is labeled as a giant fibroadenoma. The capsule is well defined. Yes, that is one of the hallmarks. And there's both glandular and cystic tissue which is formed, but the cellular appearance is monoclonal. So this is not true for a fibroadenoma. So unlike cancers, so cancers, when they arise, they are monoclonal. They are arising from a single clone of cells. Whereas fibroadenomas, you will see that they tend to be polyclonal. Okay. So both glandular and cystic enlargement can be there, but they are polyclonal. And this is a very important point which you should know, which is asked from the pathology in the exam as well. It differentiates from other malignancies which are usually arising from a single cell. This is a very important question, and this is frequently asked in the exam, and this is some place where students get confused as well. So very important question, I would say, for the MRCS exam. Nipple discharge is most suspicious of breast cancer in which of the following women? Okay, so let's look at the answers. All right. So everyone is going with B. So that's good. So 35-year-old with bilateral brownish discharge that is only visible with squeezing of the nipple. Okay. So this we need not be concerned about. So we always tell patients that it is spontaneous discharge which we are more worried about, right? If discharge is coming on their own, or the history which they give is that when they wake up in the morning, their undergarment or their nightgown has a stain on it. Those are the discharges which are more concerning for us, not the ones which one can express after squeezing. Okay. So this is not that significant. A 45-year-old with unilateral serous discharge that is spontaneous. We'll come back to this. A 30-year-old lactating mother who notices unilateral bloody nipple discharge that is spontaneous. Now, some people can get confused with this option, but in a lactating mother, to have bloody discharge for a few weeks after lactation or when lactation starts is normal. And we usually observe these patients only if it persists for a longer duration, then only we are concerned about it. So greenish nipple discharge bilaterally, this is a classical sign of duct ectasia. This is a sign of duct ectasia. And milkish discharge would be seen in multiple conditions where raised prolactin can be there. So that is also not so concerning. Now, 45-year-old with unilateral serous discharge, this is bothersome. Okay. So please understand that all bloody discharges are not cancer and all serous discharges are not benign, right? So even serous discharge can be a sign of cancer. It can be a sign of cancer. So spontaneous discharge from one side, and even if it's serous, this should be investigated further. Okay. So Mimansa is asking that Schwartz labels giant fibroadenoma as more than 3 centimeters. No, we will go with the typical description of more than 5 centimeters. We not 3 centimeters, we'll go with 5 centimeters. So I've already covered these points. This is an important question, like I told you. So we have to identify the false statement regarding the changes in breast histology with age and hormonal status. So these are the questions which sometimes bother students, because we study about all the conditions, about all the pathological conditions, but we usually miss out on the embryogenesis or the development of various organs. And that is what is exploited in the MRCS exam. Okay. So here, inactive breast, the epithelium is sparse and consists primarily of ductal epithelium. This is true. With pregnancy, minor ducts branch and alveoli develop symmetrically. So this is wrong. So it's not symmetrical development, it is asymmetric development, which is why sometimes we will get ladies and they will say that one breast is bigger than the other one, right? And there can be a difference of at least 15% to 20% as well. So it's not symmetrical enlargement, it is asymmetric enlargement. With parturition, enlargement of the breast occurs via hypertrophy of alveolar epithelium. This is true. With senescence, breast assumes a flattened, flaccid state with more pendulous configuration due to decreased volume. That is also correct. So you should know this, that it is not symmetric enlargement which is there. I'm not reading these explanations because they've been shared with you. For future reference, you can always go through these explanations as well. The additional points which I'm telling you, I would strongly recommend that you make a note of them, as they can be useful in the exam for you as well. So this is an inactive breast versus an active breast. You see that the glandular tissue is prominent in an active breast, and it is active and functioning in an active breast. So another very important question is regarding genetics. So genetics is also a very important question which you should know. And again, this is a very simple version of the question where they've asked that a doctor is a leading researcher in King's College, and she has volunteered to teach students for online government medical college in Chennai. And she asks a question, BRCA1 and BRCA2 are tumor suppressor genes, which is absolutely correct. They are tumor suppressor genes, and you're right. Now, one more tip which I would like to share with you. Sometimes, when in the exam, you might be running out of time because all the questions are very lengthy. All clinical vignettes would be around 2 to 3 lines, sometimes 4 to 5 lines as well. So it is always worthwhile that you read the last line and find out what are they trying to ask you. And then you start reading the question for hints or clues. Because many times, if they're just asking you a direct question, you need not read through the entire explanation. You'll just end up wasting time. So that's just a time-saving tip which I wanted to share with all of you. Correct. So all of you are correct. These are tumor suppressor genes. And we should know that BRCA1 is situated on chromosome 17, whereas BRCA2 is situated on chromosome 13. And these have also been asked frequently in the exam. They've been asked frequently in the exam. These are the guidelines when we should test for BRCA1 and BRCA2. And these guidelines are getting a lot of prominence these days because of a lot of agents which can be used in BRCA positive patients, and because of the increase of prophylactic mastectomies as well. So it is worthwhile remembering, when do we do BRCA testing? We don't do BRCA testing in every patient. And like I told you about the nipple discharge question, you can be given 5 options and you can be asked in which one of these would you do BRCA testing. So that can also be a way of asking a question. So BRCA1 or BRCA2 testing would be done if there is a BRCA gene in mutation in a blood relative, if there's personal history of ovarian, fallopian tube, or primary peritoneal cancer. For patients with breast cancer, 1 or more blood relatives diagnosed less than 45 years of age, personal history of bilateral breast cancer less than 50, triple negative breast cancer less than 60 years, and personal history of male breast cancer. And without a personal history of breast or ovarian cancer, first or second degree relative with ovarian and breast cancer less than 45, or more than two first, second, or third degree relatives in the same bloodline with breast cancer, at least one of them who is diagnosed at less than 50. So these are the indications, and you should know about these indications for the exam. Again, a straightforward question: which histological type of DCIS is most likely to progress to invasive ductal cancer? That is correct. And supposing there were two options, one was comedo without necrosis and comedo with necrosis, then which one will you go for? With necrosis. That is absolutely correct. Comedo with necrosis is the most aggressive type. That is correct. So DCIS can be classified into various types, and comedo type is the one which is considered most aggressive. I will tell you some more points regarding DCIS. I just want you to answer one question as well. So this is just the architectural pattern which you see in DCIS. The basement membrane will not be invaded. Now, DCIS a lot of times presents as clustered microcalcification, and this clustered microcalcification is the one which is detected on screening mammography, right? Is detected on screening mammograms. Now, here is something which I want to tell you, which is different in the way where we practice versus in UK. So when screening is done, you encounter these situations of clustered microcalcifications quite frequently. Now, if you're asked in the exam, how do we make a diagnosis of this condition, right? Supposing this has been labeled as a BIRADS 4, but it is not palpable. This would be a non-palpable lesion. You can't feel the microcalcifications. It is BIRADS 4, non-palpable. So how do we make the diagnosis? Now, a lot of you would answer it as core needle biopsy, right? Correct. So guided biopsy. Guided using what? Will you be able to see microcalcifications on an ultrasound? Can you see microcalcifications on an ultrasound? No. So that is what I want to highlight. So here, this will be a stereotactic. It will be a stereotactic guided core needle biopsy, or an MR guided core needle biopsy, right? So that is what is the option which I want you to look out for. So either mammographic guided, which is stereotactic guided, or MR guided biopsy is what we need to do in these patients. So that is something which it's a minor detail, but two options will be there, and I don't want you to mark the wrong answer, which is why I'm highlighting this point for you. Now, one more question regarding DCIS. So let's answer this question, then I come back to the previous slide. You have a 42-year-old lady who goes for an executive health checkup and is diagnosed with pleomorphic microcalcifications in the left breast. Core needle biopsy reveals it to be a comedo type of DCIS, which is ER/PR negative. Which one of the following statements is not true regarding her management, right? Not true. So simple mastectomy will be associated with least local recurrence rate. Is this true or false? True or false? Yes, MR can. Breast MR, you can see it. Ideal would be a stereotactic, but on a breast MR also you can see it. This is true. Breast conservation surgery followed by radiotherapy will be associated with least recurrence rate. True or false? No, this is false. Simple mastectomy will always have least lower recurrence rate, right? Will always have lower recurrence rate. Even after radiotherapy, there will be a marginally higher recurrence rate after BCS. right? Even after radiotherapy, there'll be a marginally higher recurrence rate after BCS, local recurrence rate. Patients will not benefit from chemotherapy. This is true. Chemotherapy has no role in DCIS, and Van scoring can be used as a prognostic score. This is correct. Van score. This is the Van score. It is mentioned in Bailey as well. You should know about the Van score, that it includes four things: size of DCIS, margin status, the type of DCIS, and age of the patient. Please remember that ER/PR status is not included in DCIS. Also, you should remember that in DCIS, we do not measure the HER2/neu status. So there is no point evaluating the HER2/neu status in DCIS patients, because it is not going to alter our treatment options in any which way. So DCIS, I told you, most aggressive is the comedo type, which you should know about, and the least aggressive is the papillary type, which you should know for the exam. Okay, 53-year-old lady has recently undergone a wide local excision and sentinel lymph node biopsy for carcinoma breast. Of the factors listed below, yes, absolutely. Manisha, there is a role of hormonal therapy in DCIS, which will be given after surgery and radiotherapy. There is a role of hormonal therapy. So in this patient, of the factors listed below, which will provide the most important prognostic information, you people are absolutely right that it is the nodal status. That is correct. So in a patient where it is non-metastatic, there the nodal status is the most important prognostic factor, right? There the nodal status is the most important prognostic factor. Whereas if it is metastatic, then what is the most important prognostic factor? Yes, what is the most important prognostic factor if it is metastatic? That is correct. Absolutely correct. So then it is the ER and the PR, the estrogen and the progesterone receptor status is the most important prognostic factor in those patients. So that's absolutely right. That's correct. So another very important thing, and a thing which is being asked very frequently in the exam these days, is the molecular classification of breast cancer. And you cannot avoid the basics of the molecular classification. Excuse me. You can't avoid the basics of the molecular classification of breast cancer for your exam. So which of the following statements regarding the molecular classification, which are the false statements? So it is based on gene expression profiling. Is that true or false? True or false? This is true. Luminal A is the most common type and has the best prognosis. This is also correct. Basal or triple negative initially shows good response to anthracycline-based chemo. This is also correct. Triple negative breast cancers have shown the best response to chemotherapy. Basal type of cancers usually have high Ki67. Ki67 is a proliferative index marker, and this is also true. And luminal B can either be HER2/neu negative or positive. So this E option got cut out, none of the above. That is the correct answer here. E option got cut out, none. That is the correct answer. Right. So this is a quick summary of the molecular classification of breast cancer. You should know the basic points. A lot of details are not asked. So luminal A is estrogen, progesterone positive, HER2/neu negative, and has a low Ki67, which is a proliferative index marker. Now, luminal A is the most common type and it has the best prognosis. Those 2 points are sufficient for you to know. Luminal B can be like luminal A, but they will have a high Ki67, whereas you can also have a triple positive, and there the Ki67 doesn't matter. HER2/neu enriched is when it is positive, and basal or triple negative type, all three are negative, And this basal type is the one which has the worst prognosis, and this is the one which is seen in young patients. But the basal type is the one which will respond best to chemotherapy. So another way of asking this is pathological complete response rates. Pathological complete response rates would be best in a patient with triple negative breast cancer. Okay, pathological complete response rates would be best in triple negative breast cancer. Now, this is again a very, very important question. And this is a question where what we practice in our country varies from what is done in UK. And when you have to mark the answer, you have to mark the correct answer here. So you don't have to mark what we are practicing, you have to mark what is practiced there in UK, okay? So a 48-year-old lady presents with a palpable, tender, mobile lump in the upper outer quadrant. The overlying skin is normal and there is no adenopathy seen on examination. Ultrasound reveals a 2.5 centimeter cystic lesion and ultrasound guided cyst aspiration is performed. Yes, what is the correct answer here? Okay, one person has answered. Can others also answer? Okay. So the fluid should be sent for cytological examination only if it is blood tinged. This is very important. So that is what I want you to remember. What we do in our practice or in India or other Southeast Asian countries, that if we are aspirating a cyst, irrespective of the color, we will send it for examination. That is not how it is done in UK. Only if it is bloody, then only it is sent for cytological examination. Otherwise, the sample is discarded. So please remember this point. This is commonly asked in the exam. Only if it's bloody, we send it for cytological examination. Straw colored fluid should prompt a core needle biopsy. No. Presence of septations is associated with a low risk of recurrence after aspiration. This is false. Septations is a sign of a complex cyst, and a complex cyst is more likely to recur than a simple cyst. Okay, a complex cyst is more likely to recur as compared to a simple cyst. Thickness of the cyst wall does not correlate with cancer risk. This is also false. If you have thickened wall, if you have a growth coming out from the wall, then all those can be a sign of a malignancy inside a cyst as well. Right? So this is an important thing which I want you to know. So also I want you to know, so if I just have to, so this is what a cyst looks like. Now, just to make things clear for you, if there is a patient with a breast cyst, which is palpable or big in size on ultrasound, then we will go ahead and we'll carry out an aspiration. Again, if it is mentioned in the option as ultrasound guided aspiration, that would be a better option. Okay. Now, if it is bloody, then we send it for examination, cytological examination. If it is bloody, we send it for cytological examination and consider a biopsy as well. Also, if it is a residual cyst, that means one which has not been completely aspirated and there is a solid component which is left, then also we need to do a biopsy. Then also we need to carry out those biopsy in these patients. So these are points which you need to remember. So Mrs. Kamala Nursing has been admitted to your surgery ward for evaluation of a breast mass. Which of the following is not true regarding triple assessment of this condition? Now, this is also something, these terms are very unique to UK, right? So a surgeon's assessment is documented in the score of from P1 to P5. This is true. Radiologist assessment can be U1 to U5. This is also true. So when we are reporting an ultrasound, it will be U1 to U5. If it is a mammogram, it will be M1 to M5. Pathological grading of C1 indicates need for repeat biopsy. This is also true and important statement for your exam. Pathologist scoring extends from B1 to B5. So biopsy 1 to biopsy 5. This is also correct. And each score of triple assessment must be given independent evaluation based on the suspicion. So all statements are correct, right? So while framing the question, all statements are correct here. None of the statements are wrong. All statements are correct. So please make that change. All statements are correct. This is not true. All statements are correct here. Okay. Now, the scoring is given from 1 to 5. I'm going to tell you, I'm just coming to that. So read the last paragraph. This is very important. When we do clinical assessment, it is prefixed with P. Radiological assessment, M is for mammogram, U is for ultrasonogram. Histopathological assessment, C is for cytology and B is for biopsy, right? C1 indicates inadequate sample or a dry tap and requires a follow-up core needle biopsy. B5 is further divided into DCIS or invasive cancer, right? So this you should know. These are terms which are frequently used in the breast units there, and you should know about them. So this is the grading. I've taken this from Medscape. This is how it is from P1, U1 or M1 till P5, U5 or M5. Now this is on the same lines as BIRADS. I'm sure a lot of you would be familiar with BIRADS, that is breast imaging reporting and data system. So it is on the same lines. So nothing is different. It's just that the prefixes are different, and that is what you need to remember for the exam. So a 32-year-old lady has a strong family history of breast cancer, right? And she wishes to undergo screening for the same. Her clinical examination is unremarkable. Which of the following is true regarding the screening options for her? So this is also an important question. This I told you is screening is also sometimes asked in the exam. So mammograms have poor sensitivity for malignancies in women less than 35. This is true, right? This is true because you have dense breasts, and in dense breasts, it is very difficult to make out a small lesion. Sonomammogram is the investigation of choice in her screening. No, that is not true. MRI is the screening modality for the young high-risk patient. So she is less than 40, she's young, and she has a strong family history. So in her, we have to do an MRI. So the correct answer is going to be both A and C. Both A and C will be the correct answer here. So look, the American guidelines and the UK guidelines slightly differ on this. The latest American Society of Breast Surgeons guidelines say that you will do both. You will do an MRI and a mammogram as well. Or if a mammogram shows dense breast, then you do an MRI in such patients. But UK guidelines are very clear that if the patient, so this is just a, so I'll just explain this to you. Shagun, I'll just explain this to you. This is the breast density grading. And what I want you to remember, that extremely dense breasts, if you see here, extremely dense breasts, where you have a lot of breast tissue is also appearing white, and a lump will also appear white. So it'll be very difficult for you to differentiate between the two. Okay. That is why as the lady ages and you have a more fatty breast, mammograms become more sensitive. So please remember, these are the UK guidelines that high-risk patients, if there is a P53 mutation, MRI is to be started from 20 years of age. BRCA mutation, MRI is to be started from 30 years of age. And young high-risk patient, like as was mentioned in the question, less than 40 is when we will do a MRI. Okay, less than 40 is when we will do an MRI. So these are points which you should remember for the exam. You've been called to provide a surgical consultation for a lady who is admitted to the geriatric ward for pneumonia. Her left arm has purple patches with subcutaneous nodules. She gives a previous history of mastectomy with axillary irradiation 15 years ago. I think so. This is a very straightforward question. Long-standing lymphedema. Long-standing lymphedema, what can you get? That is correct. You can get lymphangiosarcoma, and this is known as Stewart-Treves syndrome. This is Stewart-Treves syndrome, which is the development of a second malignancy. And this is commonly seen in a long-standing lymphodematous limb. And you need a gap of at least 8 to 10 years before this Stewart-Treves syndrome develops. It will present as bluish or reddish nodules. Now, lymphedema is again a very important topic. A lot of questions are asked. This was not there in your paper, but I want you to answer this question for me. So, which of the following is not true regarding post-mastectomy arm lymphedema? The risk increases if radiation to the lymph nodes is given after axillary clearance. True or false? True or false? If you give radiation after axillary clearance, this is true. So these days we are either doing clearance or we are giving radiation to the lymph nodes, axillary lymph nodes, not both. Sentinel lymph nodes reduce the risk of lymphedema. True or false? This is true. If axillary clearance is done above the axillary vein, the risk of lymphedema increases. True or false? This is also true. And prolonged use of negative suction drain can reduce the incidence of lymphedema. This is false. There is no link between the two, right? There is no link between the two, between the use of a negative suction drain and lymphedema risk. So sentinel lymph node biopsy, again, sometimes questions are asked. You know the techniques. This is the blue dye technique. And in the blue dye technique, we use methylene blue or isosulfan blue, which is used to identify these sentinel lymph nodes. Or we can use a technetium 99 tagged sulfur colloid. Technetium 99 tagged sulfur colloid can be used in these patients. And here we will use a gamma camera. This is a handheld gamma camera, which is used to carry out sentinel lymph node biopsy. A new technique, which is also gaining a lot of popularity in UK and in our country as well, is ICG. This is indigocyanine. This is indigocyanine green. Indigocyanine green. And the advantage of ICG is that there is no radiation exposure while carrying out this technique. So there is no radiation exposure while doing this. So it is worthwhile noting down this point. It might be asked in the exam. Right. Samira Khan, a 45-year-old lawyer, presents with complaints of a chronic eczematous eruption over her right nipple that has begun to ulcerate. Left breast appears to be normal. No mass is felt on examination. Nodes are not present. Biopsy shows large, pale, vacuolated cells. IHC S100 is negative. CEA is positive. What are we looking at? What are we looking at? That is correct. All of you are correct. This is the classical description for Paget's disease, which is commonly asked in the exam. So this was one of my case, which I had seen a few months back. She had extensive Paget's disease, and you can see that the nipple areola complex has been destroyed, right? So the nipple areola complex is destroyed here. And once the nipple areola complex is destroyed like this, it's a chronic lesion, mostly unilateral. We have to carry out a punch biopsy here. Please remember that scrape cytology is not useful, and that will always be there in the options. We don't do scrape cytology. We will always do a punch biopsy in these patients to get the diagnosis. Please remember that. Right. So most of the times this, if it's exclusively Paget's, most of the times it will be DCIS, but there can be underlying invasive carcinoma as well. Again, a common question. Renee Johnson is concerned about a drug called tamoxifen, which she's been told to take for breast cancer. She has heard that it increases the chances of cancer in the body. Which malignancy is associated with this drug? I think so. This is very straightforward. Correct. Endometrial cancer is correct, which is why we monitor the endometrial thickness in patients who are on tamoxifen. George Orwell is a young man who's come to see you because he has difficulty while driving. He reports that he sometimes cannot see cars approaching him from the sides. During your examination, you note that he has gynecomastia with discharge from the nipple. Which of the following tests would you order for this patient? So what are you suspecting in him? What are you suspecting in this patient? Correct. So we have bitemporal hemianopia, which is a sign of pituitary adenoma. So always remember that the questions in the MRCS exam, usually what they would do is that the question stem would want you to make a diagnosis first, and then the question per se would be based on that diagnosis, maybe regarding the examination, maybe regarding the investigations or the treatment. So you're correct. We are thinking on the lines of a pituitary adenoma or a prolactinoma, which can give rise to gynecomastia, and we will do prolactin levels, and we will order an MRI brain for this patient as well to look for a prolactinoma as well. So the final question from the breast module before Dr. Vinayak takes over the medico-legal aspects. Daniel Norton is a young mother who's been referred from her breastfeeding support group. And this is also a very, very commonly asked question, right? She has been experiencing severe pain in one of the breasts for a few days now, and the skin is hot and painful. Which of the following is not an appropriate treatment strategy? Simple analgesics. Yes, we will use simple analgesics. Use of a breast pump to empty the affected breast. Absolutely. If you don't empty the affected breast, the bacteria will keep on growing. Penicillin, antibiotics, if not allergic, true. We know that amoxicillin plus clavulanic acid is the antibiotic of choice. Incision and drainage if the infection persists, and ultrasound breast to check for developing of breast abscess. This is true. D is false. And in Bailey also, this is clearly written that if you have a lactational breast abscess, we will carry out ultrasound guided aspiration, and at least 2 attempts of ultrasound guided aspiration need to be done before you carry out an incision and drainage. So even after 2 attempts, if it does not settle down, that's when we carry out. Yes, Shagun, I understand that it is said if infection persists, but first we need to carry out aspiration. And only if they've mentioned that aspiration has been attempted and still the infection is persisting, then only we will mark incision and drainage. Okay. Now, one thing which I want to highlight here, and this is a very common question which is asked in the exam, and I want you people to know about this. So if you have a lactating mother, who's come with an abscess, who's come with a breast abscess, we know that the antibiotic of choice is going to be amoxi plus clavulanic acid. Okay. But they ask one more question, and that question usually is that you will have a lady in between her 40s to 50s, and she will come to you with greenish discharge, and you will have a draining sinus. You have a draining sinus with pus close to the nipple. What antibiotic will you give in this, and what is the condition which I'm talking about? I'm sure all of you know about the condition. I want to know about the antibiotic which will be given in this patient. What is the condition? Anyone? What is the condition what we are dealing with? No, not this is not granulomatous mastitis. For granulomatous mulvicus, they will mention that it is granulomatous mastitis. This is classical 40 to 50 years greenish discharge. We discussed that this is classical of ductal ectasia with periductal mastitis. That is absolutely correct. This is duct ectasia with periductal mastitis. Now in UK, you encounter these patients very commonly. And when you encounter these patients, you should know that you have to start these patients on amoxiclav plus metronidazole, and that is what the examiner will be on the lookout for. You have to give metronidazole in these patients, okay, because these abscesses, they tend to be polymicrobial and you can have an anaerobic component as well. And commonly in the exam, in your part B also, in some of the stations, when if you're given a clinical scenario, they would want to listen to this. So this is a major difference between the treatment of the two conditions. The age group will be different, the question stem will be different. I really want you to note this down because this is commonly asked in the exam. Okay. So those were the points, or those were the questions which I wanted to highlight. If you people have any questions regarding the breast module, feel free to ask me those questions, following which Dr. Vinayak will take over. He's going to be discussing a very, very important thing regarding the medical legal aspects and consent related aspects, which are very different from our country and what is practiced in UK. And there would be at least 4 questions or 5 questions based on ethics or medical legal issues. So you should pay attention to that part as well. Any questions, anyone, before Dr. Vinayak takes over? All right, thank you. It was a pleasure interacting with all of you. I'm still present in case you have any questions. I'll address them once Dr. Vinayak has completed. And I look forward to seeing all of you next week as well. So keep studying. All the best. See you next week. Dr. Vinayak, over to you, please.
Thank you so much, sir. Can you guys hear me?
Yes, you're audible, Dr. Vinayak.
So today's topic is going to be something very interesting. And we're going to be looking. Just a second. Yeah. So today's topic is going to be something very interesting and very unique to MRCS because we're going to be talking about medical legal aspects of surgery. And it's not, just medical legal aspects of surgery. It's going to be very specific to the UK. And it's very important because 4 or 5 questions are going to come. And Indian students generally find it challenging because the concept of consent is very different in India and in UK. One very important thing I want to talk about before we go into the questions is the entire medical legal aspects. You can split it into one is consent, the other is appraisal, and the specificalities of the legal NHS system in the UK, and the third is handling of certain situations. So in this particular session, I'm going to be concentrating more on consent. For information about appraisals and revalidation, it would be make more sense for you to go into the app and check out the question bank, because those are extremely theoretical stuff, not much of nonsense. So let's go into the first questions. So the first question: a 17-year-old boy, Matthew Bunnan, was riding his uncle's bike and got into a motor vehicle accident. He's brought unconscious to the emergency room where a fast scan has showed a ruptured spleen. His BP is dropping rapidly. An emergency splenectomy is proposed. Which of the following is the most appropriate action to be taken regarding consent for surgery? So do I contact the parents to seek consent? He's a 17-year-old boy. Or do I contact the social services to seek consent? Kind of makes sense because, in UK, a lot of power lies with social services. Or treatment cannot be initiated as the patient is unable to consent. Now that is illogical because he has a ruptured spleen and his BP is falling. Consent by proxy. Now that is something which we may not be really aware of. And the next one is proceed without consent. So does that make sense? I don't think so. So a lot of you have typed either D or E, consent by proxy or proceed without consent. So contacting the parents, let's go option by option. Contacting the parents is the wrong answer because in UK, the age of consent is 16 years old. Now that 17 years old is a decoy. So this option A is a decoy. So it does not make sense at all. Contacting the social services does not make sense because you don't have time. He needs urgent treatment. C, as we said, is illogical. Treatment has to be initiated. So we'll just left with two of them: consent by proxy and consent or proceeding without consent. So in this particular case, it would make sense. Guys, I would request you not to annotate. Somebody is annotating. So consent. If you're Ankur, would you be able to mute the participants who are? Yeah. So in this particular case, the answer is consent by proxy. When I mean consent by proxy, there is an emergency situation where you are not, you don't have to wait for the patient to kind of give consent. So this is called consent by proxy, where two independent doctors, one of whom is a consultant, provides consent for surgery as it is in best interest of the patient. So this is a part of consent form 4. So there are 4 types of consent forms in the UK. One is consent form 1, where the patient agrees to the investigation. So this is for normal routine surgeries and routine procedures, which involve GA. Consent form 2 is parental or person with parental responsibility agreement for an investigation or treatment for a young child or a young person. Consent form 3 is patient or parental consent, where you are say you are removing a lipoma, where there is a consciousness is not impaired. Consent form 4 is for adults and patients who lack the capacity to consent. And in this situation, we use the concept of consent form 4 and 2 independent doctors, one of whom is a consultant, take the decision for the patient. So looking at parental responsibility. So we'll be talking about parental responsibility as well. So when I talk about parental responsibility, you will have to understand the concept of Gillick competence. So I give you a hypothetical scenario. So for this question, you can unmute yourself and talk, or you can put your answer in the chat. So imagine there is a 12-year-old child and he wants to get a surgery done. It's an emergency surgery done, but his parent has some sort of religious belief which prevent the surgery from being done. It may not be an emergency, but it might be a semi-emergency. Say, for example, a malignancy which requires blood transfusion, and his father is a Jehovah's Witness. Does that 12-year-old child have the right to decide for surgery or not?
Yes.
If the patient is competent enough. The patient can give consent for surgery, but cannot deny it. So yes. So again, a hypothetical situation. A 13-year-old girl wants an abortion. Okay. She's not medically fit for abortion. Medically, there is no indication for abortion. She's well grown, but she wants an abortion. The father or the mother, they both say there's no need for an abortion. Would you go ahead with the abortion? Proceed. Can't consent.
Gillick's competence. It's about Gillick's competence.
Exactly. So this is a concept I want to talk to you about. So there is something called as Gillick competence, which determines whether a child is fit to give consent or not. So in many cases, like we find in our own government hospitals, we feel that treatment is required for a particular condition. But the parent might not have the understanding. The child might have a little more understanding than the parent. So we assess, the pediatrician, the surgeon, they assess whether the child is Gillick competent. When I mean Gillick competence is a ruling. I will not get into the legal details of it, but it basically assesses whether the child is able to understand the information, is able to weigh the implications of the decision that the child takes. Say, for example, the child says she wants an abortion. And if the child understands that the complications of an abortion, or the complications of not having an abortion, so if the child is able to understand that, and the third criteria is that the child is able to vocalize it. If the child is able to tell the doctor, the pediatrician, the surgeon, what is the problem which I am going to undergo? What is the complications of not doing this procedure or undergoing this procedure? If the child is able to understand that, then the child is deemed as Gillick competent, Gillick. So the child is competent or not competent? Yes, Sonia, the child, that is decided by the doctor. So the doctor assesses whether the child is competent. And if the child is not competent, and if the procedure is life-saving, we can go ahead using Children's Act. There's something called as Children's Act. And the Children's Act determines that the surgeon or the physician can, take a decision on behalf of the child if the parent is deemed as incompetent. So yes, there's another doubt. Consent form 1 and 3 differ only in loss of consciousness during procedure. Yes, there is no other difference. So yeah. So now let's go to the next question. Any other doubts in this particular question? You can unmute yourself and ask, or you can ask in the chat. Yeah. So the next question. Are you able to see the screen? Next question. Yeah. A 29-year-old man, Ralph Mosley, is found under a pile of rubble at a building site after an accident. His right thigh is crushed badly, and the surgeon feels that the limb is unsalvageable. He's disoriented and confused. His urine tests positive for myoglobin and is dark looking. Now that means that he's going in for myoglobinuria. The crush injury is acting on. His wife states that since his brother lost his leg in Iraq, the patient has said several times that he would rather go through anything than lose a leg. What is the right management for this patient? So yes. So what is the right? So let's look at option by option. Manage Ralph in the ITU. His consciousness level is impaired. So that kind of looks stupid, because you can't, aggressive fluid restriction is not just going to wait for, solve the problem. You need an amputation. Option B, manage Ralph using ABC principles. Ask to speak to the patient's brother. You don't know what the situation is at home, and you wouldn't want to, waste time talking to the patient's brother. C, manage Ralph on call. Attempt to call the on-call legal team. If it's at night, 11 o'clock, nobody in UK works after 5 o'clock in the evening. So that's something which you have to keep in mind. Manage Ralph using ABC principles. Following discussion with the patients, book the patient for a below knee amputation with the consent form 4. Now here is where they are testing your clinical aspect as well. So the answer, the option E is basically going in for a high amputation. I don't know if you're able to see on the screen. So the option E is booking the patient for a high amputation, and option B is booking the patient for a below knee amputation. The answer is E, which is booking the patient for a high amputation. So again, here the patient has loss of consciousness. So the decision will be taken by the surgeon, the consultant, as he's confused and oriented. The patient's wife does not have any role. You can discuss the situation of the patient's wife. You can take her opinions into consideration, but you do not need permission, and only consent is given by the consultant, which is going in for a high amputation. The patient is dying, he has a crush injury, renal failure, you have to amputate. Any doubts in this particular question? Okay, so let's go to the next question. So Gregory King, a 55-year-old man, has been brought to the emergency room by paramedics accompanied by a policeman. The policeman tells you that he's a bus driver who has just driven into a tree, injuring himself and 2 passengers. Gregory is suffering from a laceration to the head and appears confused and disoriented. The policeman asks you to obtain a blood sample to test the blood alcohol concentration, but you can see that Gregory is not capable of giving consent for this at present. What is the most appropriate action? So now this is a kind of a very confusing question. So do you take a blood sample and wait till Gregory can give consent? Is that logical? For my Indian mind, it doesn't, it seems to be very stupid. Now you've taken a test, you want to wait for him to, before giving consent. Okay, take a blood sample, wait until Gregory is alert and oriented before testing, irregardless of his willingness. Now, I think that's kind of, so what is the point of him being alert and oriented if you're not going to take his opinion at all? C, take a blood sample and give it immediately for analysis as this is a medical legal case. Now, C sounds very logical, and that's something I would do if I was in Lady Harding, Safdarjung or Madras Medical College. D, take consent from Gregory's emergency contact and draw the sample. As I've already told you before, the West is very individualistic. There is no role for the emergency contact. There is no role of the wife. There is no role of the parents. So Gregory's opinion is the only opinion that matters, or is it the state? It is the state. Inform the policeman that you can draw the sample only once Gregory is able to consent for it. So let's see. We have got a lot of opinions in the chat. Saf has mentioned. So there's a lot of conflicting opinions. So let's look at the answer. So take a sample now and wait till Gregory can give consent before testing for alcohol concentration. So the latest 2002 Police Reform Act states that it is no longer necessary to obtain consent from unconscious or incapacitated drivers to take samples. However, the sample cannot be tested till the patient regains competence and provides valid consent. A competent patient who refuses to allow his sample to be tested can be liable for prosecution. So basically, you wait for his consent, but if he refuses it, he is liable for prosecution. Don't ask me the logic. Many times, that is what the law says. There might not be logic in this, but this is what the law says. In this new way, the new law recognizes the clinician's duty to justice. So Gregory King needs to be sampled right away, but testing will wait till he recovers from consciousness, or he has a surgery, or undergoes whatever sort of treatment. Is there logic in this? Many of you might refute it. There is no logic in this. There is no point for doing this. But now that's not how the system works, and you will have to understand this and go ahead with this. There is a lot of legalities involved. So we have more detailed explanations on the question bank as well. So if you want to kind of understand this in detail, so I would advise you to go through the reference and also go through the question bank. No, there is no breath analyzer. Breath analyzer always has to be under consent, and because you're placing, it's a voluntary breath.
These points which he's raised, I think so, these are points which you really need to revise a few days before the exam as well, because these medical legal aspects, we usually get confused. We start thinking from our own country's standpoint. So make sure that these ethical points you definitely revise a week before the exam, because you don't want to get them wrong. And actually, these questions are very easy to answer if you practice them a couple of times, and if you revise them a few days before the exam. So how many of you have booked a slot for the September exam? Just so all the best to all of you who've booked a slot. Great, perfect. Over to you, Dr. Vinayak.
Yeah. I think
Dr.
you can
Vinayak is
right now.
Next question. Take care, please.
Yeah, while consenting a patient for an invasive intervention, which of the following is not information that must be provided for the consent to be valid? An explanation of benefits and risk, including probability of success. Yes, definitely logical, makes sense. B, explanation of the purpose of intervention, 100%. There is absolutely no doubt. C, explanation of whether or not the treatment is experimental and success rates, 100% yes. You cannot, this is what you do in clinical trials. D, other options for management and the benefits and risk. Yes, that makes a lot of sense. E, the success rates of the doctor who will perform the procedure in comparison to national success rates. Now, this is very controversial, and this is the answer basically. It is not an information which must be provided. So the success rates of the doctor who will perform the procedure in comparison to the national success rates. For an Indian, this is the most logical answer, and this is the correct answer. But from a UK perspective, this is very controversial, because a lot of protests happened in the UK because the General Medical Council and certain societies started publishing the success rates online. So what they have kind of made it is that the success rates of surgeons for procedures have been made online, and these have been made available especially in the field of pediatric cardiac surgery and adult cardiac surgery. This has caused a lot of controversy because surgeons are saying that they have stopped taking risky procedures. So if there's a congenital heart disease which is likely to fail, surgeons have stopped operating that. And that has meant that cardiac thoracic surgery training has become very less attractive to a lot of people in the UK. So a lot of training spots are reduced. So there are hardly around 10 to 12 training spots in cardiac thoracic and vascular surgery, because a lot of centers have shut down their cardiac thoracic programs because they have been unable to achieve a serious amount of success rates. So for a UK doctor, this is very controversial because they've been reading about this in the newspaper, reading about this in NHS guidelines, but still that has not been made a mandatory part of the consent, but it has been being made available in national registries. Any doubts at this point of time? No doubts. So I think I'll go with the next question. So while obtaining consent, which of the following is not true? Provision of translators is necessary if the patient doesn't understand the language. absolutely important. This is a very important component of MRCS Part B as well. You will have a station where there will be a translator as well if you don't understand the language. You imagine you're taking the exam in Colombo like Dr. Rohan and I did, or you are taking the exam in Malaysia, and then there will be a translator available for any station. Any member of the surgical team can take consent. Okay, now that's kind of, okay. Enough time must be given for the patient to arrive at a decision. In an Indian scenario, we just tell them, surgery karna hai abhi. Then that's not how it works in the UK. You will have to give. Consent should be taken in a quiet room. Why have people said that this is not true? Why should you not take the consent in a quiet room? You should take the consent in a quiet room. You should take the consent in a situation where the patient is very comfortable. You should take this consent in a room which is not too bright, not too dark. You should offer the patient or the attenders water, and you should offer them the option of a chaperone. You should offer them the option of having another person when they are taking consent for a major procedure, because they might want to consult with their friends or family. So the answer is any member of the surgical team can take consent. Ideally, only the operating surgeon should take consent, as other members may not be informed enough to know the details. The consent is taken in a quiet venue and enough time is given to decide. Translators are a must when the patient doesn't understand the language in which the consent is being taken. So I have mentioned the term ideally. So ideally, only the operating surgeon should take consent. However, there are exceptions. If it is an emergency procedure and the consultant is stuck somewhere else, he can depute the other person, and even then, the patient can say that I can refuse the consent till the operating surgeon takes place. So only, and even that person who is coming to take the consent should be a part of the operating team. So the answer is any member of the surgical team cannot take consent. It should ideally be the operating surgeon. Even if there is an exception, it should be a person who is going to be involved in the surgery. So any doubts in this?
So Vinayak, what about if the scenario is, a registrar at night where you have an emergency as he's waiting for the consultant? So
yes,
at that time,
at that point of time, yes. So if you're waiting for the consultant in an emergency situation, the registrar can take the consent. But
so
if the consultant is available,
should remember, everyone should remember
yes,
that a registrar in the emergency is the person who's the decision maker, and he has the discretion of calling the consultant, and the consultant, may or may not come for the surgery.
The patient can. So we have to understand one more thing. In an emergency setting, the registrar will be the operating surgeon as well. So it does not mean that the operating surgeon is the consultant. And one of the very important points in the consent is we have to inform who is going to be operating. So in an emergency setting, if the registrar is operating, he must inform the patient that I'm going to be the one operating, and he can then take consent. So is that clear to everyone? The consultant need not be present during the procedure, but the patient should be informed that the registrar is the one who is operating. So let's go to the next question. So a researcher, Professor Raj Kutrapalli, is planning a study on gastritis caused by inappropriate prescription of analgesics. He decides to perform a case control study instead of a cohort study. Which of the following best describes an advantage of a case control study over a cohort study? So people who might see the name might get the pop reference of Raj Kutrapalli. Extra points for people who mention that in the chat. If you look at our question bank, there's going to be a lot of pop references, a lot of references to Sheldon, Suits, and a lot of other Netflix shows. So anybody who kind of gets back to me on mail through that will get an extra prize. So let's go ahead to the answer, just to make things light. Yes, Professor Raj Kutrapalli is from Sheldon. And let's look at the answers. It provides information on various outcomes. B, it can be performed with minimal expenses. C, it can directly measure incidence. D, it can help analyze exposure to rarer risk factors. E, a temporal relationship can be established. So what does the majority say? Majority say D. Oh, I think everybody is smart. So yes, A case control study, let's go to the answer. A case control study, so there are two options. So a case control study can be performed under minimal expenses. So there are two options which are right, but if you had to choose one, it would going to be D. A case control study compares the characters of one group with another control. So it means that, it is independent of incidence. So it means that rare diseases can be studied. In a cohort, it's very difficult, population cohort, it's very difficult to analyze rare diseases. So there is no loss to follow, and it's relatively inexpensive and quick to perform. The results of such studies are quoted as an odds ratio. And the odds of one event occurring in one group, the odds of another it occurring in another group. So the answer is D, but B is also right. But if you had to choose one, the biggest advantage is that it helps to analyze exposure to rarer risk factors. You will have to read about case control study, and that's something which we will be covering in the question bank, in the statistics part of the question bank, and also in the video lectures. So I can't wait to talk to you about it in detail. So do wait for the video lectures as well. Next question. Which of the following circumstances is not a valid reason to breach patient confidentiality? So A, you're disclosing information to another specialist. B, you are disclosing information to the next of kin when the patient is unable to make decisions themselves. C, disclosing information to a police or social worker when the patient is a threat to himself or others. D, local authority when highly communicable disease. I think A, B, C, D all make sense. But E, giving information to a medical student. Now, this is something which we Indians are not used to. I included this point because a lot of students tend to get confused with B and E. Because I had initially told that you disclosing confidential information to the next of kin is wrong. But that is wrong only when the patient is able to make decisions. So imagine a patient has, say, a malignancy. In the UK, there is no concept that you don't tell the patient that your mother has a brain tumor, and I'm not going to tell her that because she might feel bad. No. In fact, you can't tell the son that the mother has brain tumor unless the mother actually gives permission for the doctor to reveal it to the son. So now that's how complex it is. So logically, all of you might say right E, but after hearing my talk, attending this test and discussion, you might get confused with B. So most of you are right. The answer. So the answer is E. Confidentiality is the primary duty of the doctor. So the doctor may share information about the patient in certain conditions. So usually when the patient enters, the consent form also allows the patient to say that, they can discuss the problem with other specialists. So that's usually a part of it. Medical students can be only involved only if the patient has given explicit consent for this to occur. Okay, public safety and notifiable diseases, very logical, so I'm not going to elaborate on that. So let's go to the next question. Very interesting question. 100% is going to occur. I have not known MRCS examinations of this question. So Glasgow Coma scale, basically the guy is brain dead. Who is authorized to diagnose brainstem death? So A, a transplant. So this is very, so in Tamil Nadu where I am there, so there is something called as a transplant authority, which follows similar rules. So this rule is being followed even in India. An intensive therapy consultant alone? No, a single person, definitely not. Two consultant, both post-registration must make the certification, makes a lot of sense. C, two consultant, one of whom must be a member of the transplant team. Now that makes sense, right? One of them should be a member of the transplant team. D, two doctors, both 5 years post-registration. Two consultants, it's very similar to option B. Option E, two doctors, one of whom must be a consultant, both 5 years post-registration. Neither of them are a part of the transplant team. So in a lot of places, people are surgical hungry. Surgeons, members of the transplant team, they either see surgical benefit or monetary benefit in a transplant occurring. So it is kind of understood that both the doctors, one of whom must be a consultant, both of them should be 5 years post GMC registration, but none of them should be a part of the transplant team because there is direct conflict of interest. As many of you are surgeons, you would be, kind of realize that surgeons are always hungry for more cases, and especially liver transplant surgeons, they have trained all their lives to perform a transplant. And if he comes and if he gives an opportunity, he might be tempted to say that this guy is brain dead, if he's not brain dead. And for measuring brain dead, there's a whole host of criteria which includes apnea testing as well. But we're not going to be talking about this because that's more theoretical. And but both of them should not be a part of the transplant team. In fact, there's a term for it in transplant circles. They are called transplant vultures. So it makes a lot of sense to keep those transplant vultures away from the team. So this is the answer. E is right. So I'm included this question because it tells you that pure logic is not the only thing you need for MRCS Part A. You definitely need to go through the question bank. You definitely need to go through theoretical material to understand these very nuances of NHS. I've not discussed a lot of these questions, but over the next 1 week, a significant amount of questions from various resources and also extremely updated questions are going to be added on the question bank. So I would request you to subscribe to the question bank to understand these kind of questions. Risk management, clinical audit, clinical effectiveness, cost control, and staffing and management. There is no explanation for this. It's just simple, memorizing these 7 points: clinical audit, clinical effectiveness, risk management, education, training, CPD, which is continuing professional development, patient and public involvement, use of information, staffing and staff management. So these are the 7 key areas you need to be there. So it's a very common question which has been asked time and again. Not much of logic. In fact, it was asked for me in my MRCS Part A, something very similar. I don't even remember. And I kind of missed that question. So it kind of hits you if you fail by 1 mark or 2 marks. And these are the questions which make the difference, because very easy to understand, just sheer theoretical knowledge. You can't miss these questions. Okay, something very logical. Father brings his 9-month-old child to the ER. He gives inconsistent history. Which injury most raises a suspicion of non-accidental injury? Anterior rib fracture, clubfoot deformity. Rib fractures, don't you think so? It makes a lot of sense. Clubfoot deformity, a child is going to be born with a deformity. C, femoral shaft fracture. D, hip dislocation. By hip dislocation, very common in children. Sheer shot, no. Bruising over both knees, when children, they rub their knees on concrete, they tend to bruise their knees. My father always used to say that if a child is not bruising both their knees, that means the child is not playing enough. And as we were both brothers, and till the age of 10, all our knees used to be bruised, and thankfully our parents were not prosecuted. So which of this is the answer? So there's a lot of conflicting opinions. So also some of you have said C, some of you have said A. The answer is C, because the answer for non-accidental injuries, posterior rib fractures and not anterior rib fractures. Anterior rib fractures, the chance of injury is very less. Posterior rib fractures, when you shake the child in a battered baby, the 4 fingers tend to press on the, imagine this is the thing. The 4 fingers tend to press on the back of the child, on the posterior ribs, and that tends to, hurt the child. So posterior rib fractures are more common. Anteriorly, you're just pressing your thumb. The chance of fractures are very less. Let's go to the answer. So I'm going to be discussing a little bit about this too. So a long bone fracture in a child who is still not walking. So the femoral shaft fracture is the most, if you hit a child, people hit a child with a rod. A long bone fracture in a child who is not walking is very rare, because children tend to have very flexible bones. So unless there is a heavy amount of force, a child will not hurt its long bone. So you see fractures in the humerus, you see fractures in the radius and the ulna, you see tibia, femur fractures, very indicative of non-accidental injury or child abuse. Multiple fractures in various stages of healing, definitely yes, because the child, that means the child has had multiple injuries. Corner fractures. Can anybody unmute themselves and tell me what a corner fracture is? Because that might kind of be asked. Does anybody know?
Salter Harris type 1. Salter Harris type 1.
Yeah, so basically, if you're talking about, it's basically metaphyseal fractures, Salter Harris type 1. When does it occur? That occurs when there's a torsion force. You would have seen, I don't know, but when I was in a school in UP, when I was a child traveling with my father, there used to be a very nasty physical education teacher who used to twist children's arms. Man, I was glad when I left that school, because that is the exact mechanism in which these corner fractures occur. Metaphyseal fractures are very rare in children. They cause injury to the growth plate. and are very serious injuries. And same transfacial separation of the distal humerus, same thing, twisting of the fingers or pulling the child with force. Children should be admitted to the hospital, and the child protection professional should be informed. In UK, parents are not allowed to hit the child or slap the child. So be very careful, guys. If you do have children, don't follow Indian methods of parenting. If you're going to the UK, a child can make a complaint about you. An 89-year-old woman with Alzheimer's and dementia has been placed on an elective list for excision of an ulcerated squamous SCC on a cheek. Her son shows you that he has a lasting power of attorney, LPA, and will be able to consent to the treatment on her behalf. Yes, that's right. He can consent. But which of the statements regarding an LPA, a lasting power of attorney, and consent is right? Options are too long. I'm not going to be reading it out, but let's see if these things make sense. Option A, does in health and welfare family the same? You should know about LPA to know the answer. B, which of the following is correct? So that's the answer. In health and welfare, LPA comes into effect as soon as it is registered. Is it true? Let's see. So let's go option by option. There are two types of LPA. One is in health and welfare LPA, a lasting power of attorney. Other one is a financial LPA. In health and welfare LPA allows the attorney. Attorney can be anyone. Attorney does not mean lawyer. It can be the son, friend. It can be anyone whom the patient trusts. The LPA is made when the patient is conscious and anticipates that he or she will face deteriorating mental function. So if I'm diagnosed with multiple sclerosis at this age, and I feel that my sense of I might be developing dementia, I might not be able to take decisions properly, I can make my friend, I can make any of you guys my LPA, and I'll hope that you guys take decisions in best of my interest. I really do hope. I hope you don't punish me. So that is the thing. But that comes into effect only when the patient's mental functions deteriorate. So in health and welfare, option B is wrong. In health and welfare, LPA comes into effect as soon as it is registered. No. A financial LPA, on the other hand, which allows the attorney to make financial decisions, that comes into effect as soon as it is registered. An LPA can be valid, made by anyone over 16 with the ability. The answer is wrong. It is 18. Despite the fact that the age of consent, the age a patient is considered, a child is considered an adult after the age of 16. For an LPA, you should be above 18. Same for voting. So LPA cannot be validly made. I mean, that's absolute, crap, because that's definitely wrong. Okay. Option E, if there is more than one attorney registered, they must both give consent for medical care decisions. Now, in certain situations, a parent might, make a son or a daughter, but they both need not give consent, or they both can give consent. It depends on the terms of the LPA. The LPA might have different terms in each of the each document, which say that either one or both should be allowed to make the decision. So it depends on the terms of the LPA. So option E is wrong. So, and this document LPA should be registered with the Office of the Public Guardian to be valid. Any doubts in this? Okay, so now we have a very interesting question. If there is any meher over here, do forgive me. You walked into the doctor's room at 2 a.m. and you see in your registered Dr. Meher Arora smoking cannabis peacefully while on call. She even has a pager on her while she drags the fumes into her lungs. She says she has had quite a stressful week and has only one joint to help her relax. What would you do? Now, guys, don't answer this from an Indian point of view. Don't, because I know a lot of you have seen your seniors and stars doing all sorts of bullshit while on duty. It happens in India. It happens in many parts of the world. It happens even in the UK, let's like it. But what would you do in this situation if you were in a part of the NHS? And remember, this decision has to be made the right way, because if you make a wrong decision, your GMC registration might be cancelled. As Dr. Rohan says, workplace scenario questions are extremely important, and we have a whole host of questions. I can, even arrange extra TNDs or Zoom sessions to discuss all these things, because all of you guys might have a doubt. Let's see the answers. Okay, so let's see. Okay, so as it's a quiet night, ask for assurance that this is the last time and carry on. This is what I think I would do if I was in my workplace in India. B, ask her to arrange for someone else to do her on-call for her and nothing more will be said. Absolutely not. You are concealing information. C, ask her to discuss the matter with her consultant or supervisor in the morning. But 2 to 8, who will see the duty? She is under the influence of cannabis. D, ask her to phone the consultant to self-report immediately. Now that to me appears to be very logical. The consultant is the person who's going to be involved. E, phone the GMC on-call line for service. I don't think you should be waiting. As I told you, there is nobody on the legal team. There is nobody at GMC who is going to pick up your call after 5 p.m. I think many of you guys would have experienced this. If you try to email the Royal College of Surgeons on the weekend or during long holidays, nobody's going to respond. They're going to take at least 5 to 7 days to respond. I think it's a personal scenario. A lot of you are texting me personally that yes, it's true. So let's see the answer. I think D is the right answer. Ask her to phone the consultant. So Meher should be encouraged to phone and report to herself with the consultant. And if she does not, then you should. So basically, you are asked to be a snitch, even if she is your senior. You are supposed to complain against your senior. Now it's a consultant's responsibility out of ours to deal with this in the first instance. So what kind of happens is that at 2 a.m., the consultant should come, remove her from the situation, and he should step down and act as a registrar. So that is the level of responsibility you would see in the NHS. Another doctor does not need to complete her on-call to protect safety. The consultant has to be nursing. However, the situation needs to be escalated and dealt with, not forgotten after this night shift, so that no such further issue occurs ever. It is the consultant responsibility, even if he's out of hours, to deal with this and to report to both the trust and the GMC. So the accused or the offender self-reports herself or himself to the consultant, and if they do not, you report, and the consultant reports to the trust. The trust is the organization which runs that particular NHS hospital, and then he also reports to the GMC. And once the situation is made safe, it is likely that the registrar will face both trust and GMC disciplinary proceedings in due course. His or her license might be cancelled. And if you follow the other options, if you try to phone the GMC or if you wait till morning, and if there is evidence that you have seen us smoking cannabis, then you will also face trust and GMC disciplinary proceedings, and the consultant is obligated to report you guys. So I hope you guys understand this. It's a very important scenario, very important question. Thank you so much, guys. If you do have any doubts, I think you can ask right away. And we will be making this session available for all subscribers. You will be given, you can contact the helpline 814820638. You can WhatsApp them for subscriptions. They will be able to activate your subscriptions within 24 hours. And for people who have already subscribed for the MCQs, you will be able to subscribe at a discounted rate. And this discounted rate is only because the exam is close by. So I would suggest that you use this opportunity because both Dr. Rohan and I have made an extreme amount of effort to make sure that these questions are very relevant and it plays a major role in your MRCS. So I think there's been a thing. Question number 9. What was question number 9? Okay, so there's basically nothing to explain over here. The risk management, clinical audit, clinical effectiveness, all these staffing and staff management are all a part of 7 pillars of clinical governance. So you can see in this image, it's the 7 pillars of clinical governance. It's a NHS this thing. I've taken this image from a paper, but it's all basically publicly available information. And we will be incorporating all these questions on the QBank. We will be conducting more sessions where you can ask these doubts. And I request all of you to become a part of this test and discussion, because you can schedule your preparation according to the test and discussion. Say, for example, you've done this test and discussion, you can go back home, or once the dates are announced, these 3 or 4 days, you can make sure that you read medical legal aspects in surgery and breast, so that you can align your preparation. In fact, we will be discussing, we will have a lot more sessions. In fact, after the exam also, we will be discussing the entire question paper. So even for guys who are preparing for the January session, I would suggest that you enroll yourself in this test and discussion and be a part of this. And we promise you, both Dr. Rohan and I, we take this as a personal commitment to make these sessions full of value. And we'll make sure that you go back home with a significant amount of knowledge. So.
Yeah, so as Dr. Vinayak was saying that we made an entire schedule for the test and discussion. And this will cover up all the major topics before the exam, before the September exam. So you can, utilize this schedule to do your preparation, and then you come prepared for the discussions where you can answer the additional questions and ask your questions as well, ask your doubts as well. So make use of that opportunity. We are working on the lectures. It actually takes time to record the lectures, but hopefully by July end, we will be able to launch all the video lectures as well. But those preparing for the September and the January exam, the test and discussion module would also be a useful one for all of you. So thank you very much for joining in. If you have any queries or suggestions for us, please do write to us. We'll be happy to hear that. Good night, everyone. Take care. Keep studying. All the best.
Thank you so much.